Good morning. For the first almost 15 years of my military career, give or take 12 years, something, when I'd go look at a patient, it was airway, breathing, circulation, disability, and exposure. Then after 9/11, it changed. Started with bleeding, breathing, circulation. I sort of get why though. I sort of get it. What's the major loss of life on the battlefield, folks? Hemorrhage, blood loss. Seems like I'm going back to blood every time I do a live stream about saving our blood. That's why medics are now, some medics anyway, are carrying whole blood in their medic bags on certain operations. Got to speed it up a little bit. Okay. Cut me off, fucker. Anyway, I'll go back in the day, back in 1989, learning how to do a patient evaluation at Fort Sam Houston, Texas. It was about airway, okay? Look at the airway. Basically, you're looking from the neck up, honestly, to see if it's patent, listening for the breathing. Breathing. This is where you expose the chest, okay? Check for wounds in the front. Check for exit wounds in the back. Anything that can affect breathing. Listen with your stethoscope really quick, if you had time, depending on how many people you have. Circulation. If they were talking, you know they had a pulse. Their circulation was somewhat redundant. Disability is when you would do a quick head-to-toe assessment, check for major injuries, for bleeding, pain, blood, and deformity. And then E was exposure. You expose the patient to get a good head-to-toe evaluation. I remember I had that ingrained in my head. Ingrained, okay? When I was going for my expert field medical badge, when I was in the 160th, and when I was doing it with the 75th Rangers at Hunter Army Airfield back in 1990. How many times we had this forged in our head, the training that we did before we did the testing. Then, cut 6 months later, I'm in combat, and I have 3 combat wounded folks that need me to keep them alive. Me. Hell, I was still a teenager. But guess what, folks? Anytime I'd freak out, my brain would just click back to that time: airway, breathing, circulation, disability, exposure. And it worked for me. Now, some of this you incorporate automatically. It's not one check the block, check like you're doing a pre-flight check for a MH-60 helicopter. And then I thought to myself, okay, so the biggest thing back then was, do we have tourniquets on these stumps? Yeah, okay. Well, we got tourniquets on them. We have IV in them. Let's pack the wound up a little bit. Save more blood. And that's what I do. Yeah. my brain was changed at a young age from combat. But also, I got forged more as a medical provider from having experienced that. I knew that I couldn't do anything else in my life professionally. It was something medical. But you know, originally when I joined the military, I wanted infantryman. Then I had a dream, honestly, that I was combat as a medic. I was still 11th grade, 12th grade. Yeah. Had to have been 11th grade. And I knew I didn't want to be an infantryman. I wanted to be a medic. I didn't know what it entailed. I didn't know what branch I thought I wanted to join the Army or the Air Force to be a pararescue medic or to be a paratrooper medic. I went with the Army. And it was a good choice. So here I am today. I went from being an Army medic, learning my airway, my basics, to doing full body evaluations on patients now. I'll never forget my basics, okay? So let's talk about the airway. Externally, you want to see? It's the nose functional. Can there air pass in through or out the nose? Look at the mouth. Is there trauma in the mouth? Is there an obstruction in the mouth? Is there blood in the mouth? The fundamentals of maintaining an airway, folks. Okay. Breathing. This is where you want to rip open the chest or get your medical shears and cut it open and take a look. Look for a chest wound. Look for abnormal lung movement. Look for a deviated trachea. Anything that would indicate some internal damage to the organs of the body. Use your stethoscope to listen to the lung sounds. You can tell a difference between a normal lung sound and one that's filled with fluid or air. This is just assessment, folks, quick assessment. Go to the back of the patient's upper back, feel. You can quickly turn them over and take a look to see if there's any exit wounds or entry wounds, if the case may be. But you want to do this quickly, folks. And yeah, wear gloves. Life-saving measures at this point, if there isn't a chest seal, a chest wound, put a chest seal on. Pack the exit wound in the back. Quick measures. I mean, that takes all but 5 seconds. And this is where it's good to have a dry towel and your aid bag that absorbs moisture really quick. And this is where, that's going to sound bad, to have a quick razor to quickly shave hair. If you're going to stick a chest seal on a patient, there's no sense in sticking a chest seal if it's going to not stick to the skin. It doesn't take much to quickly just shave 3 seconds. You know, I talk about that packing a wound in the back, okay? The best way to pack a open wound in the back, okay, is with petroleum gauze. The same stuff that I talk about starting a fire with. You use that to pack the wound, put some 4x4s, and then put a big dressing or tape to hold it in place. Keep that airtight as much as possible. Once the surgeon comes in there, they're going to take everything out and evaluate anyway and start the healing process. My job was to stabilize the injured. And then we went to C, circulation. Now, in CPR, which this is not CPR, circulation would be to check for the pulse, a carotid pulse. If somebody's screaming, okay, you know they have a pulse. They're unresponsive, that's something else. Circulation also meant if this was your only patient, okay, stop major bleeding, circulation, blood, arterial bleeding, clamp it. If you had the time, throw in a large bore IV. Now, here's where we went wrong back then. Instead of just saying throw in a large bore IV, throw in a large bore IV and crank up the fluid. And that's why clotting never occurred. And we changed that frame of thought. Okay, and I agree. How do you expect to form a clot to stop bleeding if you never give a chance for that clot to form, if you're constantly flushing the body with sodium chloride or lactated ringers? You're not letting the body do its thing. These are healthy young men and women. They're going to form the blood clots that they need. There's no thrombocytopenia, okay, in the military. That's why you're screened for any blood disorders. And that's why there's such a rigorous process for joining the military. Now, as a civilian, if shit hit the fan, you're not going to know if somebody is thrombocytopenic unless they have an alert bracelet. You don't know if somebody's on a blood thinner unless they have a medical alert bracelet. So you got to do the best you can. Anyway, well, back in the day, it was about putting 2 large bore IVs, cranking up IV fluid to treat for shock. Disability. Disability is when you would check for pain, blood, and deformity, going through each extremity, the upper chest, the lower chest, the scrotum, rectum, damn near killed them, and checking these body parts for pain, blood, or deformity. And if the patient's somewhat obtuse, when you press on something, or if something looks deformed, there's your cue: pain, blood, or deformity. So that's when you have, if there's no other triaging going on, meaning you have more than one patient at a time, that's where you can start packaging up an amputation, trying to preserve what tissue you can, splinting, and going back to do a full further evaluation to reevaluate your casualty. The evaluation doesn't just stop once you do your initial evaluation. Other measures, if possible, take a blood pressure. Now, back in the day, they would teach us, well, if they've got a pulse in the inguinal, they check a pulse in their groin, check a pulse in their neck, you have certain blood pressure readings. I don't even go over that because that's, one, very positional, and two, very misleading. Your best bet to check for shock is look for the amount of blood, check a blood pressure. Early shock, you're not going to have the paleness because of the epinephrine screaming through your body that's causing vasoconstriction. After everything chills, that's when you start oozing more. Okay? Now, 9/11 happened. And we started combat in Afghanistan. And we changed our thought process on how to evaluate patients, even to the point where they were learning it in basic training this way. And I had to retrain my brain thought patterns too. Breathing, or I'm sorry, it's still new to me after 30 years almost, 20 some years. Bleeding, breathing, shock, basically. All the components of the breathing, okay? All the components of the breathing. The bleeding, well, the bleeding comes first, okay? I never really liked this bleeding, breathing, shock. But yeah, you do the bleeding part first. And you apply tourniquets first that save blood because you can readjust the tourniquets after. Back in the old days, our little bullshit first aid kits, self-care aids, IFAKs, was just a stupid old-fashioned field dressing. That was it. One little field dressing. And I'm sure the packing list for the individual first aid kit has changed, but now the kit makes more sense. It has a tourniquet, has a dressing, and that first aid kit was not meant for you to work on somebody else. That first aid kit, individual first aid kit, was meant for somebody else to use on you or for you to use on yourself. Now, these first aid kits also came with a broad spectrum antibiotic, a fluoroquinolone, I believe it was moxicillin. And it also came with a pain pill, not a controlled substance pain pill, but just a pain pill, like a strong anti-inflammatory, which I thought was completely useless. But they couldn't pack vials of morphine with a needle, an auto injector of morphine with a needle, because people would just abuse it. But that's realistically what should be packed in a IFAK in combat. To control the pain. Just an auto injection, you inject it right into your hip, assuming that the bottom part of your hip's not bleeding out. Swallowing a pain pill isn't going to provide you that immediate pain relief, or having somebody else inject it in you. But the risk, some people will just take that morphine and inject it in themselves. Say, oh, I had an accidental discharge. So, unfortunately, there's some folks that will abuse that point of care. And that's how it's changed. And then they have now this tactical combat casualty care, T3C. And I believe that this T3C is great. The care under fire, making sense to don't start taking care of a patient on the battlefield while you're being shot at. As the medic, it's your job to grab that dude or lady and get the fuck out of Dodge to where you're not going to get killed either. And how suppressive fire is like putting a Band-Aid on a wound. That suppressive fire is medical care. Okay, because you're keeping the enemy from shooting back at you. Okay. So yeah, medics should carry an M4 rifle to provide that immediate care. You're not engaging in offensive operations while you're trying to defend a life. Your job now as the medic, the combat medic, to keep that person alive. And that's not a violation of Geneva Convention. Okay? So yeah, the medic should be trained, qualified with the M4, just like any other soldier, especially like a grunt. Because you get called in to do stuff. You're not just sitting back, eating popsicles, waiting for something to happen. Well, I think it's time to open up my ginger drink, sugar-free ginger drink. I did before I left. So there's some historic text in what I'm talking about today. Some of that information is really irrelevant in when shit hits the fan. What's the one thing that I didn't talk about at all, folks? Anyone that's live streaming or watching this on YouTube, anything that I skipped that typically you go over, and for good reason. I skipped it completely. Any ideas? Okay, here it is. If someone's heart stops beating on the battlefield, when you're doing this, you're not going to touch them. You're not going to help them. You can't. You don't have the resources to initiate CPR on the battlefield. You'd be lucky if there's sedated or obtunded that you could put a nasal gastric tube to protect the airway so they have some way of breathing. But no pulse, no CPR, they're done. You can't spend 5 minutes doing CPR on somebody expecting for your battalion level asset, your battalion medical level asset, or your company medical asset to continue that CPR and increase this to an ACLS protocol, advanced cardiac life support. We don't have that. Maybe in the future, we will. Maybe in the future, they'll have body armor that can do chest compressions and have a little injector thing on your shoulder or wherever, and it would inject the medication that you would need. I don't know. It's far thinking, but still. And that's a couple hundred years away, honestly. Or maybe not. Hell, who knows? But I thought about that. Right now they have those chest covers that you can put on somebody to do CPR. But what if the body armor could have a mechanism where it would do chest compressions for you? If you have it on, it would pump the blood. And maybe, just maybe, you would have a device that would shoot medication right into the left ventricle, get pumped into the bloodstream. You know, and that really makes me think more RoboCop. And I sort of get, I don't want soldiers turning into RoboCops. But the thought is there. Hell, we already have continuous glucose monitoring devices that we basically staple into the back of our arm or leg or wherever you put it, stomach, and it monitors your blood sugar. And those devices have that where it connects to your phone and you can tell what would be the difference. Bluetooth, okay? The words sometimes escape me. That could be connected to a Bluetooth device and give immediate patient feedback. Reminds me, on the fictional world in Star Trek, the shirts that the Star Trek people wore, it had medical evaluation on the shirts anyway. And then it would pick up the heart rate and the just do a quick evaluation of the patient if they had ceased. But my opinion or my take on that is a little bit more practical. I don't know where those Star Trek shirts aren't body armor. They were just basically pretend. I make a lot of references to Star Trek, folks, because I'm a Trekkie. I know I don't live in a fantasy world. Oh, shit, I forgot my wallet today. I totally forgot to bring my wallet in to work. Oh well. Better not speed today. No wonder I felt light. I totally forgot to pack up my wallet. Oh well. No, I didn't leave it here. That's airway, the way I used to know it as. Airway, breathing, circulation, disability, exposure. Well, folks, let's do a quick update today. I just want to get a feel for everybody. Anyone here ever play or train, I should say, with airsoft? I don't know. If so, what are your thoughts on airsoft as a way to train for close quarters operations or defensive operations or offensive missions, and a way to practice those skills? I can tell you what the limitations of airsoft is, hence the word airsoft. The rifles have no recoil. The tactics that are employed may be questionable if you're not really training to a certain standard. The when you shoot the little BBs, the little BB guns, or they're not BBs. I'm sorry. The little plastic things. They easily, you can't shoot them any distance. They're not meant to be shot long distance, especially if it's windy. The projectile will change easily. And what happens is you end up getting to train how to play airsoft better, not using airsoft as a means to develop your tactical skills better. So there's a difference. But yet, airsoft can be used to mil-sim live fire events, where you would actually be shooting at each other instead of shooting blanks. This is obviously going to be just geared towards more close quarters, offensive, defensive operations, room clearing, not long range patrol, and not engaging someone from 100 yards out and getting to it. Not geared towards that. It's geared, I think it's geared more toward when you're engaging that enemy at 25 meters out at the most, if that. And what happens at that point. So there is definitely a situation where the airsoft can work. And also, it's great exercise, folks. And you too, you can use your gear, or just use less expensive gear, because let's face it, you don't want your expensive PVS 14 to get hit by a paintball and get it ruined. Do you? No. So this is where I think training with digital optics comes in handy, because you have digital optics that mimic, that look like all the military grade or type of electrical optics that you can have. They have little PVS 14s, little PVS 7s that are digital. And the cool thing is they can record too. So you would get some benefit out of that in the after action review. I'm really thinking of engaging more in airsoft, see what it's more about. Or am I just turning into a guy that's going to be playing some fakeness with a bunch of other guys that are doing something fake? I don't know. We'll see. I still can't believe I left my wallet. I mean, the hell. I woke up at 2 o'clock in the morning, had slept 4 hours, was completely refreshed. I was like, okay, I'm going to sleep till 5. Well, I went back to sleep. I slept 3 more hours, woke up at 4:30, was ready to go. I had all my stuff packed, not thinking ahead, but I forgot my wallet. Anyway, if shit hit the fan today, that would be the hell of a day to do it, when I wouldn't have my wallet on me. And I have other identification in my vehicle, so don't like it's the end of the world. Anyway, I think we're going to cut it out here. Cut it out while we're ahead. Suburban Prepper. Everybody have a good day.